Very good afternoon, everyone. So, thank you very much to the organizers, the Bangladesh Oncology Club, for the kind invitation for me to be here in Dhaka today. Concurrent chemoradiotherapy is quite close to heart, as most of us in Malaysia are clinical oncology trained. We do both medical and radiation together. So this topic fits quite well for me to speak on today. And hopefully I would be able to do some degree of justice to the topic that is given at hand. So these are my disclosures, and let's dive on immediately to the topic at hand. So the hallmark of cure in non-small cell lung cancer lies in the ability to perform surgery. If the lung cancer is unresectable, generally the concept of cure is no longer quite applicable, and that was what has been thought in the past. And radiotherapy has almost always taken a second seat. If we look into data from conventional radiotherapy of doses about 60 to 70 grays, 1 year survival is about 40% and 3 year survival is less than 10%. And many people have actually even cited that, rather than doing radical radiotherapy, even if you do a palliative radiotherapy of just 10 fractions or 5 fractions, your outcomes are not going to be any different. So there has been some improvement in the way radiotherapy has been delivered through the process of hyperfractionation. So hyperfractionation refers to the technique of reducing the size of the dose and giving more doses over a period of a similar or a slightly shorter duration of time. So one of the most important trials in lung cancer happens to be the CHART, which is a continuous hyperfractionated accelerated radiotherapy, whereby radiotherapy is given three times a day, over a period of 12 days continuously, including weekends and public holidays. So what was then noticed was that early survival, 2 year survival, was about 9% in the conventional arm versus 20% in the CHART arm. And if we look into another concept of hyperfractionated accelerated radiotherapy, this is HART. This is dropping the continuous portion, which means you do 3 times a day, but then you break it on public holidays and weekends. That gives a rise to a survival difference of about 20%, between the two arms. So it's still not that great because survival still seems to be quite dismal. So the role of chemotherapy in concurrent use with the use of radiotherapy was definitely a very important point to note. And the role of chemoradiotherapy, or CRT, in unresectable stage 3 non-small cell cancer can be done in a sequential fashion or a concurrent fashion. But the main question here is, if the cancer is unresectable, is chemoradiotherapy then curative? So in the age that we live in today, we will not be able to do a randomized controlled trial comparing surgery and radiotherapy. That will be absolutely unethical. But the only space where which such data actually exists in stage 3A non-small cell lung cancer, which is the N2 disease populations. And this is not an exhaustive list, but this is just 4 picked up trials. And as you can see, in this very difficult to treat group of patients with 3A and 2 disease, the survival outcomes are quite similar when chemotherapy is used in conjunction with surgery or used in combination with radiotherapy. So that is a proof of concept that radiotherapy could be curative in the setting of unresectable non-small cell lung cancer. And therefore, the question then lies, how do we then position chemotherapy and radiotherapy? Do we give them sequentially, one after the other, or do we give them concurrently? So this is a meta-analysis that looks into concurrent versus the sequential chemoradiotherapy approach, looking into the concept of overall survival, as that will be the outcome that we'll be most interested in. And what has been shown is that concurrent chemoradiotherapy is associated with an improved survival as compared to sequential chemoradiotherapy. And as we can see, the hazard ratios from the various trials actually support the use of radiotherapy given concurrently with chemotherapy. However, concurrent chemoradiotherapy is very toxic. So as you can see in this particular table, you could see the treatment-related deaths ranges from about 2 to 3% with the use of chemotherapy and radiotherapy, definitely a lot more in the concurrent arm as compared to you just giving radiotherapy alone. And what is of very, very importance to us as clinical oncologists and radiation oncologists is the management of esophagitis, where almost 15% and maybe up to 20% in some series do develop grade 3 and 4 esophagitis practice, limiting their capability to actually complete the treatment as a whole. And the other issues, of course, with regards to myelosuppression, neutropenia, is also very, very rampant with the use of chemotherapy and radiotherapy concurrently as compared to sequentially. And despite all that, chemotherapy, radiotherapy, all given in together, yes, it's very toxic, and yes, it's very useful. But yet, if you look into the hallmark studies, the median survival is less than 2 years. So 50% of our patients would still die within the 2-year mark, even if we give them the best combination possible with chemotherapy and radiotherapy. So how could we then do better? So generally in management of non-small cell lung cancer, the principle, of course, lies in improvement in diagnosis and staging. So FDG PET-CT has definitely changed the way we actually stage patients now. And in the field of radiotherapy, it has also changed the way how we volume the cancer for the purpose of radiotherapy. Brain imaging has almost always become mandatory these days. It used to be mandatory in small cell lung cancer, but now in non-small cell lung cancer, we also want to know in presence of brain metastasis. And of course, with the introduction of invasive mediastinal staging, with mediastinoscopy, EBUS, and TBNAs, have all improved the way we stage and we stratify them, and then we prognosticate them a lot better. Technological advancement also cannot be denied. There's definitely improvement in the surgical approaches. Our patients are definitely having shorter hospital stays, faster discharges, less complications. And at the same time, radiation technologies have also very much improved with the introduction of newer equipments, ability to deliver much higher precision radiation. And of course, a lot of developments in the field of adjunct systemic therapies as well. But looking into chemoradiation per se, how could we then make it better? Should we then give some chemotherapy first, and then we should give some chemoradiation? Or should we give some chemoradiation first, and then addition of some chemotherapy? Should we use advanced radiation techniques? Should we dose escalate? Should we change our chemotherapy approach? So let's look into all these 5 questions in a very brief way. So induction chemotherapy in general terms should not be adopted in the setting of chemoradiotherapy. If you're going to do chemoradiation, you either do it sequentially or concurrently. So you should not do induction chemotherapy and then concurrent chemoradiotherapy. That concept has been tested in multiple trials. This is not an exhaustive list, and they have all consistently shown that there is actually no survival benefit. But in all honesty, in settings whereby resources are limited, we tend to give a couple of cycles of chemotherapy just to buy some time so that we can actually put them on the machine to actually have the treatment. But having to say that actually doesn't confer any survival benefit in its true sense. So how about you give concurrent chemoradiotherapy and then you consolidate the treatment with systemic therapy? Now, this strategy has also been explored in multiple clinical trials. Again, this is 4 selected trials that shows that even if you give chemotherapy, such as docetaxel monotherapy or docetaxel and cisplatin, dual therapy, it doesn't make a difference. In unselected patients who actually received gefitinib, this is a very old study. In fact, gefitinib as a consolidation therapy was detrimental. In fact, patients were dying a lot earlier when they actually received gefitinib as compared to them receiving placebo. And of course, the use of anti-EGFR antibodies such as cetuximab also did not result in any improvement. So a lot of things has been done, a lot of play around, with the agents that we have, and nothing has actually ever improved the outcomes of concurrent chemoradiation. So, okay, never mind. Let's ignore the chemotherapy bit. Let's now look at the radiotherapy bit. Is using advanced technique going to be better in improving survival of patients with non-small cell lung cancer? We don't quite have head-to-head comparison with the use of standard 3D conformal radiotherapy and intensity modulated radiotherapy. Intensity modulated radiotherapy definitely reduces the doses received by organs at risk, and therefore reduces short-term and long-term toxicity. But whether that truly translates into a true survival benefit has not been known. We do have some data from large cohorts of real-world data that shows that that may actually be the case. So how about dose escalation? Should we then escalate the doses from 60 grays to 70 grays to 74 grays? So this is actually the study that is very frequently quoted to say that you shouldn't do that. In this particular study, which is RTO G0817, the use of higher doses of radiation was actually detrimental. But bear in mind that this was actually using very old techniques, very old equipments. The toxicities to the heart and the lungs were not very well controlled. So we don't quite know whether this really holds the same fact in the advanced age that we actually live in right now. But the general recommendation, if you ask most people, is that they probably wouldn't exceed the doses more than 66 grays in the concurrent radiotherapy approach. So there has been a lot of interest, especially during the COVID days, on how we can actually deliver radiotherapy with a shortened fractionation schedule. We call it a hypofractionation. You deliver higher doses per fraction, shortening the overall treatment time, also with the ability to slightly push up the doses, the total doses that has been received. This is very much hypothesis generating. The trials are actually very, very small, but it definitely looks encouraging, but with the caveat of increased toxicity. So anytime you increase a dose per fraction, you are definitely going to subject the patients to more toxicity. Whether that is something worthwhile in order to improve their survival, that is yet to be determined. So how about the concurrent approach? Should we then change our chemotherapy regime? So this is definitely one of the very, very useful studies, which is called the PROCLAIM study, that actually showed that you can actually replace your classical vinblastine, cisplatin, or paclitaxel carboplatin with pemetrexed and cisplatin. So pemetrexed, as we all know, is a lot better tolerated, and as a concurrent chemosensitizer, definitely works just as good as the classical agents, mainly in comparison with etoposide cisplatin. Right. So this is where we are headed. But these studies that I have shown you so far are all not without its own criticism. So it is very difficult to actually properly interpret, all the radiotherapy studies, because the evolution of the technology is as such. So radiotherapy studies are conducted over a period of 10 years, 15 years. And by the time the study is actually published, the technology has actually gone way further from when the study was actually started. So whether the studies that are published truly holds relevance to the practice that we have today is definitely that we need to rethink. There is a lack of patient-reported outcomes in radiotherapy trials. So we know patients survive better. We score the toxicities, but are the patients actually tolerating the treatment? How are the patients scoring their impression of the toxicity? We don't quite know about that. There is a lot of overlapping toxicities with comorbidities, smoking being a predominantly common risk factor. A lot of our patients have got ischemic heart disease, diabetes, hypertension. How does that interplay? We don't quite know. There is lack of standardized dosimetry. So if you do a multi-institutional study, the radiation quality assurance is not likely to be the same between the two institutions, and there are very, very few protocols that actually standardizes them. And of course, the ever-evolving and changing TNM staging. So the stage 3A that was reported 20 years ago may not really be a stage 3A today. So that is, again, another thing to look into. And despite all our best efforts, our patients are still not doing as well as they're supposed to. The survival still remains dismal. And so I will then move on to the next bit of the talk, looking into the consolidation approach. So we know that systemic therapies, targeted therapies have all failed, and then came in immunotherapy. So immunotherapy basically is a strategy of harnessing a patient's own immune system to actually target on the cancer cells in the hope that that will actually result in programmed cell death. So the concept of immunity is very much well established in immune checkpoint inhibition, whereby in a normal state where a patient has got cancer, the programmed cell death receptor that is expressed to the T cells are masked by the ligand that is produced by the cancer cells. So the cancer cells live prosperly in the individual, and the immune system of the individual doesn't recognize these cells as foreign. But with the use of PD-L1 and PD-1 inhibitors, this cascade is then blocked. The immune cells recognizes the cancer cells as foreign, and therefore they come into effect. And the drug that is most relevant in the treatment of non-small cell lung cancer is durvalumab, which is a PD-L1 inhibitor. So the efficacy of durvalumab has been demonstrated with the use as a consolidation therapy following chemoradiation, either sequential or concurrent, in the PACIFIC study. And this is the 5-year update, which was actually published about 3-4 years ago, in 2021, that was when it is. It's a very simple design, durvalumab versus placebo. And this basically shows the characteristics of the patients are very well balanced between the two. And what we can see, majority of them received concurrent chemoradiation, and majority of them received good doses of radiotherapy. So that's actually very important. And what we know is that there is definite overall survival benefit with the use of consolidation durvalumab, with a median overall survival of 47 months versus 29 months. And these kind of data is almost unheard of in any of the other publications that I've shown you earlier, and this is definitely something very, very impressive. And the reason as to why the placebo arm also did well was because these patients were very, very well selected and stratified. But again, as per any new agents that is being included, we have got to be wary of the immune-related side effects. So generally, the adverse side effects are similar between the two arms, but of course, there is definitely a lot more immune-related side effects, such as hypothyroidism, pneumonitis, and dermatitis associated with the use of durvalumab. And the story doesn't stop with the Pacific trial. So this is, again, not an exhaustive list of the various other consolidation immunotherapy approaches that has come into place, with the use of either atezolizumab or nivolumab or pembrolizumab, or nivolumab and ipilimumab in combination. So these studies, this is a graph showing median progression-free survival. The overall survival for most of these studies have not been published. There is also a lot of interest in the use of dual immunotherapy, combining with anti-TIGIT agents and anti-LAG therapies as well. And they are all out for us to interpret. But at the moment, Pacific still holds the fort. So just a little bit of a point on the age, because the topic that we are at hand today is mainly looking into driver mutations and its impact. In the field of chemoradiation, somehow driver mutations have been very much neglected. And the subgroup analysis from a Pacific trial actually showed that if you give consolidation immunotherapy, it actually doesn't make a difference if the patient has EGFR mutation. And the most recently published LAURA data actually shows that if you supplement the patients with osimertinib, post-chemoradiation, that actually confers a survival benefit. So in conclusion, chemoradiotherapy remains the most feasible curative strategy in unresectable, locally advanced non-small cell lung cancer, and the strategies to improve outcomes are definitely evolving. Consolidation with immune checkpoint inhibitor following chemoradiation has now become the new standard of care, but its adoption remains questionable, especially in low middle income countries. With that, I thank you.